Hello, everyone, and welcome to our Essential Tremor Virtual Education Forum. My name is Patrick McCartney. I am the Executive Director of the International Essential Tremor Foundation. Today, we're going to be hearing from Dr. Rodger Elble, who will be talking about ET+. But before we get started, I want to thank our corporate partners, Cala Health, Boston Scientific, Praxis Precision Medicines, Steadyware, Incytec, Villamball, and Allevion Therapeutics. All of their support allows us to provide these educational webinars and our podcast series that we do regularly throughout the year. So I want to introduce our speaker for today, Dr. Rodger Elble, who is a member of the IETF Medical Advisory Board. Dr. Elbe graduated from Purdue University in aeronautical engineering in 1971 and then enrolled in the MD and PhD program at Indiana University. His PhD thesis described the mechanisms of physiologic tremor, and upon completion of his neurology training in 1981, he joined the faculty of Southern Illinois University School of Medicine in Springfield, Illinois, where he rose to the rank of professor and became their first chair of neurology. His principal research interests have been the mechanisms, quantification, and treatment of tremor disorders with an emphasis on ET. He has developed electrophysiologic methods and clinical rating scales for the characterization and quantification of physiologic and pathologic tremor.
So this is the first time that I've been asked to talk about Essential Tremor Plus outside of a research conference. And so I'm optimistic. I think that probably the audience will understand this a lot better than a lot of the researchers, because for some reason this has been a very controversial topic, and I think the controversy is really unwarranted. So the goals today will be to define Essential Tremor Plus and explain why Essential Tremor Plus was proposed in 2018 by a task force of the International Parkinson and Movement Disorder Society. So this term, Essential Tremor Plus, has not been around for very long. The definition of essential tremor has never been consistent. One of the first formal definitions of essential tremor was in 1990 by an ad hoc group of investigators called the Tremor Investigation Group. And they met for a couple of days in Houston, Texas, and reviewed the literature, and based on the literature and their own experience, they proposed that essential tremor be defined as a tremor syndrome involving the upper limbs and possibly other body parts. There should be no other abnormal neurological signs. Isolated tremor in the voice or the head did not fulfill the criteria of essential tremor, so this was not called essential tremor. It could be mild, moderate, or severe as long as it's symptomatic. There were no specific amplitude criteria. And with the hope of this syndrome being a stable one, the Tremor Investigation Group proposed that the tremor duration should be at least 5 years. Shortly thereafter, a consortium at the NIH said that, well, you could have isolated head tremor, and oh yeah, dystonia is okay as well. And then the Movement Disorder Society in 1998 said isolated head tremor was okay, and you didn't need any duration requirement. The widget criteria basically agreed with the original TRIG criteria, except To exclude enhanced physiologic tremor, the widget criteria included some amplitude severity criteria. And then an investigation group in Spain, the Nedices group, said that isolated head tremor was okay. We needed amplitude criteria, and the duration could be a year, but it could even be less if you have a family history. So you see what's happened here is that you have so many definitions, and it makes it almost impossible, if not impossible, to compare studies that use these different criteria. So Günter Deutschel, a friend and longtime colleague, an expert in tremor, was president of the Movement Disorder Society and decided to convene a task force to look at the classification criteria for essential tremor and all other tremor disorders. He was also the lead author on the original paper in 1998. So this was basically a follow-up to the 1998 effort to categorize various tremor types. And he asked me to chair this task force. And this task force consisted of researchers, clinician researchers with a vast experience in tremor. And for over 5 years, there was very intense discussion and review of the literature. And by intense, I mean email exchanges, sometimes on a daily basis, meetings in person, and so on. This was not a casual effort. And then the results of this task force were published in 2018. So what came out of this? Surprisingly, all of the other tremor disorders, other than essential tremor, got through reasonably unscathed. And I'll show you some data supporting that in a moment. But one thing that the Tremor Task Force agreed on is that you can't have multiple definitions of essential tremor. Essential tremor is a syndrome, meaning it is defined on the basis of clinical manifestations. And in order for that syndrome to be useful, it has to be defined consistently. And so after much discussion, the task force concluded that the original TRIG criteria were fine, were most appropriate. But they said, well, maybe 3 years is enough of a duration. 5 years would be better, but 3 would suffice. So basically, we revert after all this time back to the TRIG criteria. Now, how is the diagnosis? How do clinicians diagnose essential tremor? It's really a diagnosis of exclusion to a large extent. Basically, a patient appears in the clinic with the complaint of tremor. And remember that it is generally agreed that essential tremor must affect the upper limbs. It can affect other body parts, but the upper limbs must be affected. And then the clinician performs a careful exam looking for other neurological abnormalities that might help define the underlying condition causing the tremor. And these abnormalities would include myoclonus, which are sudden body jerks, but can also produce a tremulousness, ataxia, such as hereditary ataxias, Parkinsonism, and dystonia. Those are the most common conditions that can present with something looking like essential tremor. If the clinician does not find any other neurological signs, then the diagnosis of essential tremor is made. However, there's a problem. The problem is that skills and opinions among clinicians vary. So two skilled and honest clinicians can examine the same patient and arrive at different conclusions. For example, if there's a slight head tilt or a funny hand posturing, one clinician may say, this is definitely dystonia. Whereas another clinician may say, well, this is just idiosyncratic. It's just a normal variant. And then another clinician might say, well, I'm really not sure whether it's normal or not. And this is why ET Plus was developed, because we are confronted every day, we clinicians are confronted every day with patients that have questionable dystonic posturing. Maybe they're a little unsteady when they walk, but they're also 80 years old. Maybe they're a little slow. Maybe they have some mild memory loss. Maybe they have some sensory neuropathy in their feet. Well, is that really relevant to the tremor disorder? And when it comes to very mild memory difficulties and funny posturing of a body part, you have to ask, is this really abnormal? And so that's why Essential Tremor Plus was established. Basically, Essential Tremor Plus is essential tremor and one or more of these questionably abnormal signs or a sign that is questionably relevant to tremor. For example, I'm 80 years old and I'm having forgetfulness. Is that really related to the tremor syndrome or is that some comorbidity? And so with Essential Tremor Plus, the clinician no longer sweeps these questionable signs or additional signs under the carpet or make excuses for them. They're just simply documented. And it's really a clinical medical way of saying, I'm not sure if this is essential tremor or something more. So once again, the movement disorder definition of the essential tremor syndrome is isolated tremor of the upper limbs, at least 3 years duration, with or without tremor in other locations, such as the head, voice, or lower limbs, and an absence of other neurological signs, such as dystonia, ataxia, and Parkinsonism. Virtually identical to the original Trigg criteria. Essential Tremor Plus is tremor with the characteristics of ET and additional neurological signs of uncertain significance or uncertain relevance to the tremor syndrome. And included in this was tremor at rest. A small percentage of patients with the diagnosis of ET have what appears to be real rest tremor and no other signs of Parkinson's disease or dystonia. But because this is so uncommon, in the general population of ET patients, it's probably present about 5% of the time. It was concluded that patients with tremor at rest should be classified as ET plus. So when I give these definitions, right away, I have people asking, what's the difference between a syndrome and a disease? Well, a syndrome is simply a group of clinical manifestations that suggest a specific disease or condition. So let's use a common example. So the clinical manifestations, I go to the doctor and I have a runny nose, a cough, and a sore throat. And the doctor was a very good student and he diagnosed, well, you have a common cold. It's actually a common cold syndrome because there are many etiologies of the common cold. There are at least 200 viruses that cause the common cold syndrome. And it's not really worth time and money to find out which of these viruses. But it wasn't too long ago that if you presented with a common cold syndrome and also said, well, I can't smell anything anymore, then the doctor is going to say, we check you for COVID. That's the etiology, is COVID-19. So now we have COVID-19 induced common cold syndrome. So we have an etiology and a syndrome. The disease is a COVID-19 infection. So I might have COVID-19 in my nose or on my skin because of some contact with the patient, but I do not have COVID-19 disease because I have not been infected and mounted an immune response yet. This illustrates an important point, is that any disease, almost any disease, especially COVID-19, can produce multiple syndromes. In this case, I presented with a common cold syndrome. However, I could have presented with acute respiratory distress syndrome and required mechanical ventilation. And so that is an important point when it comes to any discussion of essential tremor, is that essential tremor may simply be one manifestation of an etiology that can produce multiple syndromes. As a rule, any syndrome has multiple possible etiologies. And it appears that essential tremor has many possible etiologies, mainly genetic, but there may be environmental factors as well. And this is an important point that I will get back to later, is that a patient's syndrome can change. So I could present with a common cold and be sent home after a COVID-19 test and develop respiratory distress syndrome that night. So now I come back and I still have a COVID-19 infection. I no longer have a common cold syndrome. I now have adult respiratory distress syndrome and require mechanical ventilation. So let's look at ET. Once again, ET is a syndrome. What are the clinical manifestations? Well, my head, my hands, my voice shake. The doctor examines me and finds action tremor in the hands, head, and voice. This has all been present for at least 3 years. I'm not even sure why or when it started, because it started so gradually. A lot of people in my family have it. And so I don't really know the etiology, but I have an ET syndrome. This meets all of the criteria of the MDS definition of essential tremor. Since I don't know the etiology, it may be genetic. I say it's idiopathic because I don't know the gene or genes that are producing this problem, but it appears to be familial. What about ET plus? Well, it's a syndrome as well. Once again, I go to the doctor with the same history, same exam, except I now have a strained voice. Now you could say, well, he lives in Nevada and his voice gets dry and his voice is raspy. Or maybe this is laryngeal dystonia, vocal dystonia, like Bobby Kennedy Jr. has. And but since I'm not sure whether this is just my voice, like Bill Clinton, or is this something more, I say this is ET plus syndrome. I'm not sure. And I still don't know the etiology. It still appears to be familial. But now there has to be the management of the condition isn't so clear cut. because I, as a clinician, have to consider the possibility that if this is a dystonia, then that could have an impact on, for example, where I put an electrode for deep brain stimulation, or how deep brain stimulation, or how a patient might respond to deep brain stimulation. So it has bearing on the bears on the prognosis. And if this is dystonia, there are specific dystonia genes that I might test for it. So what about if I present with definite dystonic voice, like Bobby Kennedy Jr.? Well, now it is no longer ET plus. We say this is a combined tremor syndrome because the patient has tremor, but also other neurological abnormalities related to the tremor that are these abnormalities are definitely related to the tremor, definitely abnormal, and definitely define something more than essential tremor. And having seen that, we call that a dystonic tremor syndrome. And it may still be idiopathic and familial, but perhaps I will do genetic investigation and find a dystonia gene that is producing what superficially might be diagnosed as essential tremor. So once again, the precision at which these diagnoses is made has a big impact on etiology, prognosis, and treatment. So after this 2018 paper was published, a lot of clinicians, tremor researchers went back and looked at their old clinical data, their old diagnoses. And here was a paper out of Toronto, Canada. And they looked at a cohort of patients. 133 of the patients were diagnosed as essential tremor. But when they applied the new criteria, they said, oh, yeah, there were some funny signs. And these 133 patients, 110 were reclassified as essential tremor plus. Only 20 of the 133 continued to have the diagnosis of essential tremor. So this is very common, probably more common than classic pure essential tremor. It's worth noting that patients with other diagnoses prior to 2018, there was virtually no change in any of those diagnoses. So the new MDS criteria for the various tremor disorders had virtually no impact on the diagnosis of these combined tremor syndromes. So here's one of these questionably abnormal signs. The task force called this these signs soft signs because they really weren't hard and fast abnormalities. And this condition is commonly referred to as spooning. And what am I talking about? I'm talking about the way there's some flexion at the wrist and then the spooning contour of the hands. And you see it's a little more on the right than the left. Well, this lady didn't have dystonia. This lady didn't have tremor. This lady had migraine. But I make a habit when I examine patients to look for these signs that other investigators think are indications of conditions like dystonia. And I can guarantee you that if you come from a family of dystonia, and you walk into a dystonia clinic with this hand posturing, it's going to set off all kinds of alarms. And yet this lady had no family history of tremor or dystonia. And I've seen this many times in normal people. And here is a photograph of the Tremor Investigation Group back in 1990. And you will see that Professor Ali Rajput from Saskatoon, Canada, has this spooning, but he does not have dystonia. Peter Lewitt, pretty straight. Here's the founder of the Essential Tremor Foundation, Bill Kohler. He kind of has a droopy head. Here, Leslie Findley, pretty straight. He started the Essential Tremor Foundation in the UK. Joe Jankovic, pretty straight. Ken Schwartz, a little droopy, and unfortunately, the photograph doesn't include Mitchell Bryn quite fully here, but this is Mitchell Bryn, an expert in botulinum toxin, and he has some spooning as well. The only person with the perfectly straight arm is yours truly, and I've had this writer's dystonia in my right hand since age 25. So this is what I mean. These signs they never seem to be there when you need them, and they're there when they're probably just a spurious finding. So how do we deal with these questionable signs? And I can guarantee you in the older population and in children and adolescents, you see lots of questionable signs. Making diagnoses of dystonia in a child or adolescent much more difficult than in a 30 or 40-year-old adult. So if you look at the figure on the left, essential tremor, we have the definition, no other signs. But if we have one of these questionable signs, we say ET plus. And I may originally have an examination consistent with ET, but as I get older, I start showing telltale signs of that are possibly abnormal and indicate another condition. And so my diagnosis changes to ET plus. And no surprise, ET plus is more common in the older populations. But I might have ET plus for a good reason. Maybe I truly have a dystonic syndrome that later on becomes quite evident. Dystonia in the neck, or maybe the voice, or maybe the hand. And now I'm diagnosed with combined tremor syndrome. So you can see how one classification, one syndrome can evolve into another. And it's not a one-way street. What if I have ET plus because I've got some kind of brain fog? I just can't remember things. I can't concentrate. I've got this essential tremor appears, but I have these cognitive difficulties that are unexplained. And my doctor finds out that I have bad sleep apnea. I get treated for this. My brain fog goes away. And now I revert to essential tremor. And what about combined tremor syndrome? Well, maybe I've had ET for many, many years, and then I start exhibiting signs of Parkinsonism, and I'm diagnosed with a Parkinson syndrome now. But my doctor discovers that I'm taking a medication that can cause Parkinsonism, such as metoclopramide, or any neuroleptic, and I'm taken off this drug, my Parkinsonism goes away, so I revert from a combined tremor syndrome back to ET. So it becomes a game of searching for every clue possible, and then you have to consider the probabilities. And people are now looking at this. They are investigating what the prevalence of these questionable signs is in the normal population, the essential tremor population, and populations of patients with other conditions. And here in this table, you see an example of some other findings. And then what is the probability that it's ET and not something else. Well, if I have an ET-like syndrome and my doctor finds questionable bradykinesia, I'm too slow. My face, I have a little bit of facial masking, maybe. I have a little stiff gait. I'm just slow. The odds of that being really ET, only 15%. If I have rest tremor, the odds of it being only ET, less than 50%. If I come in with questionable dystonic posturing, like that spooning, it's a coin toss. If I come in with a little bit of unsteadiness, especially if I'm older, maybe I just can't do the state trooper test, the tandem gait test anymore, or stand on one leg, the probability of ET is pretty high. It's quite likely that this balance issue is not related to the tremor. Same goes for cognitive impairment. So you see how this works. Well, what if I have two of these questionable signs? Well, it becomes a game in probability and statistics using the Bayes theorem. And basically, if you have two or more of these soft signs, it becomes more likely than not that you do not have ET. You have some sort of combined tremor syndrome. So let's look at an example of how this works. So the patient comes in with isolated bilateral upper extremity tremor for 1 year, just 1 year, very strong family history. No one knows the genetic abnormality, but it appears to be familial. So we say that this is an indeterminate syndrome, indeterminate tremor, because it hasn't been really around long enough to be sure. But 2 years later, the patient comes back and definitely has all the manifestations of ET. And the diagnosis or the classification of the tremor is changed from indeterminate tremor to ET. And then 3 years later, now I have a strained voice and my head just seems to be cocked slightly. But I'm not sure of this being abnormal. This might just be me. The way I'm holding my head in a peculiar way. So I say it's ET plus, and I say the patient no longer has ET. The patient had previously had ET, so we say antecedent ET. Right now, the syndrome has changed to ET plus. But a year later, I clearly have vocal dystonia, cervical dystonia, the tremor is worse, and now I have a definite dystonic tremor syndrome. I previously had ET, but I no longer have ET. And I do genetic testing and I find a dystonia gene that is the underlying etiology. So let's summarize what I've said here. So ET plus is diagnosed when patients exhibit ET plus additional signs that are questionably abnormal or questionably relevant to the tremor. And I gave an example, memory loss, impaired balance, or neuropathy in the feet. This could be age-associated abnormalities or a comorbidity. It's totally unrelated to ET or the tremor, but I have to be intellectually honest and pursue it as though they might be related. But I also have to look for other etiologies. For example, a drug that might be causing Parkinsonism or obstructive sleep apnea that might be causing memory loss. And then ET and ET plus are very common tremor syndromes, the most common tremor syndromes. They're not specific diseases. And it appears that there are probably many genetic abnormalities that contribute to these syndromes. ET and ET plus may evolve into something entirely different, such as dystonia, Parkinsonism, and hereditary ataxia. And why do we bother with all of this? Because it is generally agreed that careful clinical characterization of patients generally leads to better treatment and better diagnosis. And the treatment and the diagnosis go hand in hand. So that, I hope, explains ET Plus and why we bother with this new. It's really a diagnosis of uncertainty. And honestly, sometimes clinicians are just too busy or too proud to deal with uncertainty. But it's a necessity. And I think the new classification of ET Plus is important because it helps hold our feet to the fire. Clinicians, it fosters a clinical curiosity and honesty that are very important. So thank you very much.
Thank you, Dr. Elbe. We appreciate you taking the time to speak with us today and share some great information on ET Plus. We hope everyone found the presentation to be very helpful and informative, and you learned something new today. I know that I definitely did. If you have any questions regarding essential tremor, we encourage you to visit the IETF website at essentialtremor.org, or you can call us toll free at 888-387-3667. And finally, if you are a donor to the IETF, we thank you for your support. And if you aren't currently a donor, we hope that you will consider a gift that will help us continue to do the work we're doing, promoting ET awareness, education, support, and research. So the IETF will continue to host a variety of these ET educational events, such as the webinars and our podcasts. So look for notices about these events in your Tremogram e-newsletter, on our social media channels, and our Tremor Talk magazine. So Dr. Elbe, thank you again for joining us today. We appreciate your time and hope you have a great day.